Now I am presenting a rare case of inborn error of metabolism. It is congenital deficiency of homogentisic acid hydrase leading to accumulation, especially in cartilages, a blackish tissue with the destruction of the joints. It occurs wherever the cartilage, also in any other connective tissue, including heart valves, lungs, etc., etc. They will be passing a black colored urine. When you heat it, urine will be very black. So this is ochronosis, otherwise called phenylketonuria, otherwise called alkaptonuria. I am talking about the orthopedic point of what is going to happen. So 58-year-old male came with bilateral knee pain for 5 years. Pain gradually progressive in nature, aggravated by sitting cross-legged and squatting, and relieved temporarily on medication. No history of trauma, fever. Complaints of giving way, feeling of the knee.
Sorry for interrupting, sir. Sir, I think your audio is still very low, sir. Maybe there is some speaker or something that you'll have to increase, sir.
Sir, for me it's okay, sir.
Yeah, for you it's okay, yeah? Okay. Then
For others.
Yeah, it's quite clear.
Clear, sir. Clear, sir. You can continue, sir.
Says knee is giving way. Am I audible?
Yes, sir. Yes, sir. You can proceed, sir. It's clear.
Okay. Type 2 diabetes mellitus, systemic hypertension for 15 years or oral medicines. Recently diagnosed with the alkaptonuria on 19/5/24, elevated urine homogentisic acid values 3490. Complaints of joint pain over both shoulders and elbow. Normal bowel and bladder habits. No smoker and alcoholic for about 25 years. Local examination, swelling is there, tenderness is there, range of movement up to 90 degrees, crepitus is there, valgus and varus test negative, no distal neurovascular deficits. This is the X-ray. Opinion, please. What are the difficulties you face? Not only orthopedic point, others also.
Sir, here on X-ray, it looks like typically like more like an inflammatory arthropathy kind of picture.
Okay.
Other than that, I think it, I mean, orthopedic wise, it will be more like dealing with an inflammatory type arthropathy. Other than that, general complications, I'm not sure what all we have. Generally, it's a kind of a runs a very slow course with very late manifestations. It's not like some of the metabolic disorders where it presents in early childhood or something like that. In the urine, again, you notice the dark color only if you let it stand for a while. So it goes unnoticed also in many cases.
A synovitis component can be there, sir. Some calcific plaque-like things can be seen in the X-ray. So inflammatory thing.
No, sir, the typical the radiological feature is having a meniscal calcification. And even in the spine, we have intradiscal calcification is a typical feature for ochronosis. Whereas considering these kind of patients, they normally present like a typical osteoarthritis, old age 60 plus or 70 plus. They don't have any early onset of symptoms or not. They are like same like a typical osteoarthritis presentation. Though this X-ray looks like more like inflammatory arthritis, I think rest of the course of plan of action for a total knee arthroplasty should be same as for any other case. But when you open, you might find some surprises. Those who have missed it, preoperative diagnosis of alkaptonuria, or they might find some process of seeing a black color discoloration on the bone, cartilage, synovial tissues. So rest of things should be same. So retrospectively, we can find out, we can ask the patient whether the urine turns black. They could see some sclera blackening, facial malar eminence blackening. These are the typical features we can find on these patients.
Sir, intraoperatively, I feel like in right side there's a lateral, I have a lateral condyle hypoplasia, sir. We might need for a more external rotation in this case, sir. And then tibial plateau also there is some central defect might be there, sir, on right side bone defect. Not
In
much.
this case,
Yeah,
in
sir.
this case, sir, definitely not, sir. This is a concentric joint space traditions. You cannot say any hypoplastic condyle with this X-ray. And
Okay.
I think rotation and all judgment should be intraoperative decisions. Nothing atypical on based on ochronosis point of view. And what I
Okay.
mean so. The rest is a normal total knee replacement.
Okay. Good.
It's because you can see quite a bit of calcification in the synovial pouch, suprapatellar pouch. So yeah, I think one of there is a limited flexion, isn't it?
Yeah, 90 degrees painful.
90. Yeah. So I think a synovectomy should be included as part of the procedure, so that it will also help to debulk the joint and maybe influence the cuts to some extent. I think from what you can see, the synovium will be much more hypertrophic than what is visible on the X-ray.
Aesthetic point of view.
So that's what the spine has an intradiscal calcification, sir. They might have difficult spinal anesthesia.
Also, heart may be also weak. Lung may also be involved. GA also may be contraindicated. Any other point, or shall I move?
We shall proceed, sir.
These are all the spine X-rays and shoulder X-rays. Hip. He says he will be happy if he walks with a better knee. Though X-ray looks very bad, he deliberately wants both the knees to be pain-free. Cardiologists say it's a very high risk for GA. Pulmonologists said it is a very high risk also. With the explaining to the patient, you can give anesthesia. Anesthetist said you can't give GA, you will give only spinal, you will give only 2 hours time. Whatever you want to do, 2 to 2.5 hours, you finish it. Otherwise, it will be left incomplete. We can't go for any general anesthesia or anything. MRI spine. Extensive degeneration and all the cartilages are lost in the spine. So it's a systemic disorder, both the lungs, heart, cartilage, everything, the homogentic acid gets accumulated with the destruction of the joint space wherever it is. After multiple attempts, 45th attempt they gave a spinal. And surgery time given was 2.5 hours. The case of ochronosis with bilateral severe osteoarthritis of the knee, procedure done, bilateral total knee replacement. This is on opening the first knee. Cartilage, everything looks black, totally destroyed. This is other knee when it is opened. I did bilateral within 2 hours. I didn't even do trial reduction because in buccal purpose, before you cut, whether the gap is going to be there better, and even before the bony cut is made, you can balance the knee, you can see how the collateral works. So no point in wasting time by doing trial reduction and all. I just made a cut. Flexion and extension gap are made to be equal.
15,
Right,
12 months.
Yes.
Chennai Ortho Arun Kanan.
Straight away implanted the knee without trial reduction. Finished within 2 hours. This is one knee. This is post-op X-ray. I didn't release any ligament. I used kinematic alignment with oblique joint line. Any comments? No external rotation in the femur. 3 degrees varus cut. Buccal purpose, you have to take a posterior slope of 7 to 9 degrees, just like an LCS. I didn't release any ligaments because ligaments are all weak. If you try to do mechanical axis alignment, we may lose the collaterals. This is an absolute indication for a kinematic alignment.
Much of synovitis inside there.
Synovitis I removed, but I never touched any of the collaterals or anything.
No, collaterals, of course not. But I mean, was there a lot of bulky synovitis picture in this
Everything removed.
suprapatellar pouch?
Most of X-ray is clear, no? Whatever is black, I removed it.
Wow.
There is a misconception that buccal purpose is not compatible with the kinematic, CPAC, whatever is. I am doing mechanical axis alignment, I am doing kinematic, I am doing CPAC also. I am taking mechanical axis cut without releasing any ligaments also. Everything is possible by gap balancing method. If we have a proper flexion and extension gap balance, you can fit in all the philosophies into this. You can amalgamate measure resection technique, gap balancing technique, and the buccal purpose surgical technique. Again, you do achieve whatever you want to this way. This is a workhorse of my total knee replacement, which I am doing it for more from the LCS days onwards. I never ever touch any other knee. It gives very good results in my hands.
Do you measure the varus or valgus of the components on post-op X-rays? Is that something you measure at all, or it is not of any consequence?
We didn't do any measurement, just eyeballing.
I mean, so the target would be, I mean, just to get the spaces equal in extension, you will adjust the varus valgus, or I mean, how is it, sir? I mean,
this technique is first tibia cut first. Once the tibia is okay, then you take the anteroposterior cut and flexion balance. Once the flexion balance is good, then create the equal amount of extension space. That is over, we can finish it, and even without trial reduction, I am confidently I have implanted both this and finished within 2 hours. Anesthetists were very strict. We can't do anything to this patient other than the spine. That too after 45th attempt.
and
What is
Normally,
the
I don't put a drain. In this case, I put drain because the soft tissues are not there. If it bleeds,
yeah, this is looking good. But I mean, the homogentisic acid gets deposited in the cartilage, right? And basically it interferes with the nourishment of the cartilage. That's the pathology. That's how the cartilage degenerates faster, isn't it? Is that the metabolic? This thing is, I mean, it doesn't look when you see the cartilage, it doesn't look like it's got any deposits as such. You know, it looks like whatever is causing the black coloring is almost part of the cartilage. I mean, it's the structure of the cartilage. It's sort of very diffusely mingled with the cartilage, and the cartilage seems to be just worn out, like you're saying in osteoarthritic knees. It looks worn out, but is black. So have you come across any sort of any other basic science study as to what causes decreases the lifespan of the cartilage?
Yeah, manage the knee. Whatever I know is total knee replacement.
Yeah, that of course is
I'm
the
not a
final.
physician to go into
Sir,
all the detail.
Sir, sir, we have gone through a lot of literature, sir, but what it has said is it doesn't, it takes a normal osteoarthritic course, sir. So it doesn't have like an inflammatory, it comes at the early ages. So it goes with the normal OA changes, sir. With as the age progresses, it comes with 60 plus. Those patients operated, the mean average is more than 60 years of age. That's what literature says.
Yeah. I mean, so the ochronosis is actually incidental, almost like an incidental.
Most of the time, sir. Most of the time, we find it incidental, sir.
It
The patient fails to.
Doesn't seem to influence the outcome. Doesn't seem to influence the longevity of the implant. It's not that loosening rates are any higher than any other condition. So, because even in inflammatory arthritis in rheumatoid, for example, I mean, they do behave differently as compared to all the osteoarthritic knees. Because earlier we were saying that this is more like an inflammatory process, but there's not much of a inflammatory element. It is more like an osteoarthritic knee. And even though homogentisic acid is there, and the deposits are there and sort of causing diffuse blackening of everything, there's not much of an inflammatory response, I think.
The other thing, I mean, in a primary joint, I mean, this is a diagnosed case of alkaptonuria where multiple joints are involved. There are, I mean, like I remember Raj Khanna showing a case much earlier on where, I mean, the diagnosis was kind of intra-op. Only after he opened the joint, he found the black deposits and then thought of ochronosis. So if you come across a black joint, primarily you open a knee and come across black deposits, is there any other alternative diagnosis to be considered, or is this the only one? That's
Villonodular synovitis.
Yeah, I think the picture is quite classic actually.
Here it is classic.
So villonodular synovitis will be more a yellowish tinge, sir.
yeah, yellowish orange tinge. Yeah. Okay.
Yeah, villonodular, yeah, quite different in terms of the
Siderin deposit, hemosiderin.
So the bottom line would be to send histopathology if you find it as a surprising finding. And if any case of seronegative rheumatoid we think can open, we can find some surprises like this. Can it be taken, sir?
I don't know. I mean,
I guess if you come across a black deposit in a primary joint, yeah, I think we'll have to label it as I mean, ochronosis.
Yeah, ochronosis, of course. But I mean, remember the last time I had one of these ochronosis, which is not as uncommon as we think it to be, you know. I mean, I distinctly remember some presentation in the spine or the hip or the knee over the last whatever number of years I've been here. I mean, offhand, I can tell you, I must have heard at least 15, 20 presentations on ochronosis in some form or the other, either in the spine or the hip or the knee, or even some scope pictures of ochronosis